Welcome everyone this morning. We are very, very pleased this morning to have two outstanding world-renowned speakers on the topic of focal cortical dysplasia. Our first speaker is going to be Professor Jim Rutka, who is the chair of surgery at the University of Toronto and neurosurgeon at Sick Kids in Toronto. And Jim is going to talk to us about the molecular genetics and surgical management of FCD. So without further ado, because Jim needs no introduction, Jim, thank you so much for joining us.
Thanks very much, Guy. Welcome everyone around the world, and thanks for organizing this webinar. I think it's a great idea to have webinars like this on epilepsy surgery techniques, and this is a great webinar series, so congratulations to the organizers, and special thanks to Christian Dorfer, who invited me and who's a former fellow of mine at Sick Kids Hospital. So I'm going to do something a little different in my presentation today. I thought I would talk a little bit about genetics of focal cortical dysplasia briefly, and then I'll get into some of the epilepsy surgery techniques that embody this type of a presentation. So hopefully you'll find this of interest, in, especially if you're neurosurgeons. You don't often get a chance to see this information, but I think it's actually very relevant. So when we think about lesional epilepsy, a whole variety of diagnoses come to the forefront, and I'm listing a lot of them here. But in the bottom corner of left side, you can see cortical dysplasia is here. And it's one of the most important types of epilepsy surgery that we see, and of course involves neurosurgeons. But the gamut, the range of things that cause epilepsy in patients is quite extraordinary. Most of you remember this from your basic biology and genetics days about single gene mutations, variants in genes, and chromosomal imbalances, all of which can lead to genetic disorders. But there are also mitochondrial disorders and epigenetic disorders that I won't get into in any detail today. These are some other single gene disorders that can manifest as epilepsy, and I'm just highlighting some, like tuberous sclerosis. You see there, here's Sturge-Weber. But at the bottom, I've listed megaloencephaly, hemimegaloencephaly, and focal cortical dysplasia, because as I'll tell you, they share a common genetic pathway and link. And that pathway is the PI3 kinase AKT pathway. And this was recently discovered and has proven to be an important pathway in the genetics of epilepsy. Some images here taken from this article in Brain that you can see relating to hemimegaloencephaly and focal cortical dysplasia, as is shown down here. Again, these mutations in these pathways are extremely important. When you look at the map of the genetics of focal cortical dysplasia, these are some of the other players. So PTEN, AKT3, PI3 kinase, mTOR, cyclin D2, and these can all lead to disorders of epilepsy and can all present as different forms of focal cortical dysplasia, which I've highlighted here in the circles for you. So you might want to just take a moment to take a look at this pathway in large and then focus in on where the red circles are, because that's where focal cortical dysplasia takes place. And it's tempting to speculate that, you know, if you have these weird dysplasias and you have a pathway that's active and mutated, then what about, you know, pharmacological inhibition? And here's just some drugs that can target the AKT pathway. So it'd be interesting to see in the future if there's a role for any pharmacotherapy for patients that have, you know, mild forms, let's say, of epilepsy and have been treated with anticonvulsants, let's say, and haven't worked effectively. What about the AKT pathway? Could you target it? So just tying it all together and wrapping up the genetics of epilepsy, focal cortical dysplasia, you can see is here. It's a very important player in the AKT and the PI3 kinase pathway, but you also have the tubulopathies, lissencephaly, pachygyria, polymicrogyria, and those are all related to mutations in the tubulin genes, just to throw that in for you to see. So what you should know if you're a neurosurgeon, single gene disorders, which I mentioned, PI3K and AKT pathway, they're multifactorial, chromosomal and mitochondrial disorders, tubulopathies for lissencephaly and polymicrogyria. And one wonders whether in the future, just as we've seen with SEGAs, you know, for tuberous sclerosis, where we have drug therapy, What about drug therapy for focal cortical dysplasia? Anyway, we'll see in the future whether that plays out. Okay, so that's just a bit on the genetics. Now I'll move quickly into the disorders of focal cortical dysplasia. These are some of the cases that we treated recently at Sick Kids, and you can see they can be small lesions. The lesions are shown in pink on your screen, and or they can be quite large, as you can see in the bottom left panel. So yeah, in the future, it will be relevant for us to do genetic testing of these types of cases. You know, FCD can occur anywhere. This is frontal lobe epilepsy and cases, a lot of examples of focal cortical dysplasia, something I'll talk about in detail, which is bottom of sulcus dysplasia. So these are things that are definitely amenable to surgical treatment. And the bottom of sulcus dysplasia is usually focal cortical dysplasia type 2. They can be small lesions, but they can cause fairly profound epileptogenic disturbances. Schematically, this is what bottom of sulcus dysplasia looks like. You can see at the bottom of the sulcus, and they can be very difficult to identify. And we're very fortunate, as I'll show you, that we have a special trained neuroradiologist who helps us identify these lesions. And so here, for example, is bottom of sulcus dysplasia. It's the area contained within the yellow circles that you see here. And this is our neuroradiologist, Dr. Wajaja, who's just expert at finding these. You know, all of us who've been around have read thousands and thousands of MRI scans over our lifetimes, but I dare say that we would miss these if we looked quickly at an MRI scan. But having somebody with the eye of a trained epilepsy neuroradiologist helps us identify these. And look at this small lesion within the cortical spinal tract. How would you tackle this one? It's a very interesting case. You see the pink surrounded by the cortical spinal tract in the DTI in yellow. So technically, small lesion here, there's the cortical spinal tract in yellow. Small lesion is in pink that you see. 10-year-old intractable epilepsy, failed multiple medications. These are sometimes hard to target, and this is after we had actually identified the lesion. We decided we'd put a depth electrode into the area because even though you can see the lesion on MRI and you can use navigation, you just have to trust me on this one. Sometimes it's hard to find these, and it's nice to have a fence post or a guidepost leading you into the direction of where this lesion actually is. And so placing a depth electrode right into it and then leaving it in place as we did a transsulcal approach to it allowed us to find the lesion very readily and make sure that we excised it completely. So technically, that's an interesting approach to some of these very small areas of bottom of sulcus dysplasia. We actually published on this using depth electrode placement for bottom of sulcus dysplasia in Journal Neurosurgery Pediatrics. Here's a video, hopefully you can see it, where we're following a depth electrode that was placed simultaneous with a grid electrodes array that was on the peri-Rolandic area, doing a biopsy, which we frequently do to characterize the lesion in more detail. And then we knew exactly where ground zero was for the epileptogenic zone by virtue of the recordings, and then we were able to excise it. And the tissue feels completely different when you're operating on these, and that's how you know you're in the right area. And you want to be sure you're in the right area, especially here deep within the peri-Rolandic area, as in this 17-year-old who had focal motor seizures that we operated on with this approach, essentially. Yeah, so if you're resecting near the Rolandic area, you want to be right on target. We placed depth electrodes into it. Here's the schematic in advance of that, where we placed our depth electrode. And here we are now. It's another video that will show you how we approach these. Afterwards, you'll see this small transsulcal approach, and having taken these out, very, very helpful to have a guide taking you down to where the lesion is located. 10-year-old male with this lesion here, just behind the DTI of the cortical spinal tract. depth electrodes placed right into it. This was in the days when we were doing more grid electrodes, which we're not doing so much of these days, but time to time we still are. But the depth electrodes you can see are placed through openings in the grid. And this is what it looks like. You can see the depth electrodes that are placed. And this is a video that demonstrates exactly what I was talking about, getting into the gray matter, knowing which electrode number is where the bottom of sulcus dysplasia is found and situated, doing biopsy, again, like this, so that we have tissue. And then you'll see just completing the resection. It's actually, although these are small lesions, many of them are somewhat more extensive than you would think. And the gray matter is extremely tough compared to the surrounding white matter. And of course, when compared to normal gray matter, but again, in the perirolandic region, you want to be right on target and be sure that you're excising only the lesion. So that's one technique. We sometimes cut a window out of a grid if we're using a grid, placing depth electrodes, and then follow those depth electrodes into the small area bottom of sulcus dysplasia. I just want to move briefly to the treatment of FCD using laser ablation. So it's MR guided. And many of you on the line know all about lasers. I won't spend too much time elaborating on the technique itself, but it's been very useful, as you see here, for temporal sclerosis, callosotomies, SEGAs, focal cortical dysplasias, and hematomas. And the literature in the world is rapidly advancing with respect to how you can use laser ablation for treating lesions such as FCD and getting into areas like the insular area. This is what you need to get started. We actually have the Monteris system, but Visualase is also capable of doing the work the same way, and neuronavigation, workstation, epilepsy team. And finally, it's not an inexpensive undertaking, so you want to make sure that you have the necessary funds to get this off the ground, this initiative. So it's Lexel frame-based. Draping is kind of interesting as you're putting in the laser bolt. The workstation I mentioned, access to an MRI scanner. Our OR is right next to the MR, and we actually do have intraoperative MR, but we find it just easy to just transition the patient from the room next door into the MR suite. The Monteris system is what we have. And I mentioned that it's important to have a relationship with your vendor because they can troubleshoot for you as you're doing these cases. So let's look at this case, a 12-year-old, frontal lobe epilepsy. You can see in pink area here. Hyperkinetic seizures, everything was concordant, mesial inferior basal lesion as shown here. So we approached this open at first, and it was a navigation-based type of resection. And it showed itself to be focal cortical dysplasia. Great early outcome, but then seizures came back. And it was thought that the seizures were related to a small remnant of dysplasia close to the fornix. And so we wondered whether laser would be the way to go after this. So here's what our radiologist said was a residual lesion that you can see. A tricky area to get to, open. So we elected to do this with the laser. So here it is, the setup for it with the Lexel frame. Here's now two separate trajectories because of the configuration of the lesion itself. Here's a video, I think, of the laser burn. I won't show all of it, but I'll just speed along so you can see in real time how this looks. Yellow indicates a slightly lower temperature in terms of the laser burn. It's heating up, and then the blue that comes into play indicates a higher temperature that causes necrosis. So I'll just speed this up so you can see at the end the blue area, which is there. So that's what we targeted. I think that was a good approach for this lesion because it was fairly geometrically difficult to imagine a single probe and also an open approach getting here. And this is the immediate post-procedural MRI scan that you can see here. Another case, 11-year-old, intractable epilepsy, right frontal localization, everything. But, you know, look at this. You can't really pick this out, but I'll tell you, here's the lesion here, and here it is here. And it takes the eye of the radiologist sometimes, as I mentioned to you, to find some of these lesions. Two separate trajectories and bolts were used for this because it spanned a sulcus, which bottom of sulcus dysplasia does. So technically, you have a heat sink in a sulcus, so you may not get the laser to go across the sulcus. So that's why we used two separate trajectories. This is the immediate post-procedural area that was treated with the laser that you can see here. And this child has done extremely well and has had no seizures after surgery, no neurological deficits. This is this particular case, and the video shows yellow on the first trajectory, the bolt that you see there, and I'll just speed it up. And you can see the blue color, yellow turning blue there, which indicates the temperatures at higher, around 46 and higher centigrade. And then the second trajectory is over here, about a minute here. Yeah. And so now we're using the second trajectory on the other side of the sulcus to be sure that we get the entire bottom of sulcus dysplasia as is shown here. Okay, and then we've moved into the realm of robotics, and we recently acquired a robot at Sick Kids, and we've been using it for the placement of the laser. And I'll just conclude, mostly we were using it for SEEG, which is helping us to speed up the placement of the electrodes compared to the Lexel frame-based. I just want to finish with the hypothalamic hamartoma, a large one. I think you'd all agree this is a large hamartoma. And 5-year-old with intractable epilepsy, giant hypothalamic hamartoma that's outlined here for you. And how do you approach these? I've done them always. I've done them open, endoscopic, and most recently with the laser. But we placed the laser probe with a robot, and here's our initial burn that you can see here, but we left some attachments, which is not unexpected with these large hypothalamic hamartomas. And this is now the second burn next to the first burn, trying to disconnect the left side of the hypothalamic hamartoma. And we've learned over the years, we've got to cover our kids with steroids in order to be safe and to allow them to have good recoveries and quick discharges from the hospital. But there's the second burn. Sometimes they require more burns. We're still determining if this one will be improved to the point where nothing else is needed, or will need to do more. And seizures are much better at this stage, but it's early. And these are among the most challenging cases I think we face. So to use the robot, just for those who maybe don't have robots or in areas of the world where just not accessible to robots, it takes a lot of people to get this set up as well with the laser ablation. So for focal cortical dysplasia, all of these things are at our fingertips here. I'll just leave this on for a second so you can see how we can approach these areas, especially peri-Rolandic and so on, with as much safety as possible. And I'll just conclude, we've learned a lot through advances in neuroimaging. Our MR sequence is linked to navigation. Frequently, I'll excise focal cortical dysplasia just navigation-based without any other technologies required. And that's an approach which I think you'd all agree is a good one. If you can go there, if you have enough proof leading to that lesion as the cause of the epilepsy. Surface and depth electrodes, we've been doing more in the way of SEEG of recent than grid-based recordings. Robots, lasers, I mentioned. We don't have responsive neurostimulation, but maybe others can comment on that afterwards in regions where this is being used. And so other ways to use the laser and so on for disconnecting networks, callosotomies, even hemispherotomies now have been described. But we must track our patients longitudinally to be sure that we have the outcomes that we so wish. So with that, I'll conclude and look forward to Dr. Rao's talk, who's following me, and then any questions in the question period, be happy to answer those. Thanks very much.
Great, thank you so much, Jim. So as we said, if you have questions specifically, you can type them in the Q&A window, and we'll get to them at the end of both talks. Our next speaker, we're fortunate to have from Bangalore, India, Professor Bhaskara Rao Malla, who is the recent former chair of neurosurgery at the National Institutes of Mental Health and Neurosciences, and is professor of neurosurgery there also. and he is going to talk to us about surgical techniques in focal cortical dysplasia with representative cases. So Bhaskara, thank you so much.
I hope you can listen to me and then see my presentation.
Yeah, we can see it's good.
Yeah. First of all, I'm thankful to the leadership of this webinar series. Your efforts will benefit not only young neurosurgeons worldwide, but also eventually people with epilepsy. I hope my presentation will complement to that of excellent presentation by Professor Rutka. I have no financial disclosures. I wish people worldwide get the sort of care which Professor Rutka has mentioned. But unfortunately, much of the resource poor regions of the world do not have even basic epilepsy surgery programs. We in India are fortunate. The founders of Neurological Society of India initiated epilepsy surgery programs in 1950s. I had a historical opportunity to redevelop the epilepsy surgery program in India in early 90s, following the advent of video easy telemetry as well as magnetic resonance imaging, and developed a model epilepsy program along with my neurologist colleague, Professor Radhakrishnan. The progress since then is quite impressive. Over the past 25 years, 12,000 epilepsy surgery procedures have been performed across 50 centers in India. Most of the experience is confined to this end of the spectrum, where lesion and focus can be identified easily and can be resected. But today we are talking about the malformations of cortical development. People with these disorders require complex and innovative pre-surgical evaluation strategies as well as surgical management. And in India, we are making progress in taking care of people with these disorders. These are recent publications from some of the institutions in India. At NIMHANS, over the past 10 years, we took care of about 150 people with various malformations, and were able to achieve outcome at par with the established centers. And I'll present a few illustrative cases, and you will see a common pattern in these cases. To develop a surgical technique, we have to have a strategy, and the strategy is dependent upon the underlying substrate causing drug-resistant epilepsy. So in every person, we attempt to identify and resect the lesion as well as focus to cure and control the epilepsy. I'll start with this young girl who presented with hypermotor seizures since early childhood. Both the ictal onset is in the right frontal region, and you can see there's a large cortical dysplasia in the right frontal region. Being non-dominant and non-eloquent area, en bloc resection, the gross total resection of the lesion was performed, leading to a cure of her epilepsy. This child came to us from Bangladesh, the confinement by the family is to prevent child wandering and then injuring himself during the seizures. This child presented with two different semiologies. One is a hypermotor seizure, and the other one has got intense ictal fear. This child had ictal onset in the left frontal region, and then there is a large malformation in the left frontal region, and he again underwent gross total resection of the malformation. You can make out here this is the olfactory tract and this is the caudate ventricle, and up to we went up to Broca's as well as up to the premotor area and performed the gross total resection. Now he's able to attend to the school and enjoy his childhood. This young man presented with seizures of temporal lobe origin. You can see there's a dystonic posturing of the left upper limb, suggesting seizures of right mesial temporal lesion, and then he has got ictal onset in the right temporal lesion, and there is a large developmental lesion in the right temporal area with very well demarcation. Again, this is the vein which was this is the right temporal area, right sylvian fissure. This vein actually was very nicely demarcating the malformation, and then he underwent gross total resection of this abnormality, which has got both polymicrogyria as well as nodular heterotopia. This the extent of resection can be appreciated on the imaging. Probably this boy will help us to understand our strategy. This boy presented with frontal lobe seizures in childhood, and 18 years ago when imaging was done, there was a large developmental malformation in the right frontal lobe. But when he came to us, he presented with temporal lobe epilepsy. And so there is an evolution from frontal lobe epilepsy to temporal lobe epilepsy, and imaging showed dual pathology. This is the nodular heterotopia in the right frontal region, which caused secondary hippocampal sclerosis. So there was a discussion whether to do invasive monitoring and then plan selective resection of the one or the either. But with consent and consensus with the family, it was decided to resect both lesions being in the non-adjacent as well as in the non-eloquent parts of the brain. So he underwent hippocampal resection and as well as resection of the nodular heterotopia. You can make out the white matter here, and then there is a nodular heterotopia, and again white matter, and then the cortex. And this is the extent of resection, and then this is the histological the tissue. And for nearly a decade, he is enjoying seizure free life. Electro clinical concordance is a very crucial part of our workup, and I'm sure you will realize in this seizure semiology. Hypermotor seizure. Bimanual automatism. Bimanual post.
What is your name? What is your name? Remember the color green. Remember the color green. Okay.
From
What happened?
posturing in hyper.
What is this? What is this?
This seizure is clearly extra hippocampal, neocortical, possibly from the supplementary motor region. And he's easy showed spiking in the right anterior head region. When we looked at his imaging with this electroclinical concordant background, this is what we found: the bottom of sulcus dysplasia with transmental sign, which Professor Rutka has mentioned. So he underwent circumferential en-bloc resection. You see, this surface was apparently normal, and the sulcus with the dysplasia has been identified with navigation. And then our attempt is to reach all the way up to the ventricle. You can see we have reached up to the ventricle there anteriorly first. And then this is the dysplastic tissue, which is quite firm compared to adjacent white matter. And then once we reached the ventricle, you can see CSF is coming there. Once we found the dysplasia at the ventricular end, then we went all around circumferentially and then resected the complete dysplasia. And you can see this the surgical specimen, and this is the extent of resection on the imaging. And for a decade, there are no seizures. This gentleman presented with temporal neocortical seizures, and then he has got a lesion, glio neuronal tumor within the Wernicke's area. So he underwent awake craniotomy, and then we were inside the lesion, and then till we approached apparently normal surrounding tissue, it has been resected completely. And this young man presented with the glio neuronal tumor, and then pre-surgical workup led us to do extended lesionectomy. Here you can see there's a prominent vein of labe in front of the lesion. So you can see the bone indentation by the chronic lesion. And then this is the glio neuronal tumor, and vein of labe with a large number of opercular branches. So after the lesionectomy, there was a persistent spiking even from the brain under the vein of under this vein of labe, which led us to resect even that part of the brain area, just leaving a small area to support the vein of labe. This young lady presented with the frontal lobe seizures, and then you can see here there's a phase reversal at F3, and she has got a large developmental lesion extending all the way from cortex to the ventricle, and very on the dominant hemisphere, just in front of the motor cortex, as well as very close to the Broca's area. So she underwent implantation, which revealed that the anatomical abnormality has got no functioning tissue, and the seizure onset is actually from the anterior part of the lesion, which helped us to do gross total resection of the lesion. even depth electrode study showed that in the anatomical Broca's area, there was no speech activation. So we went all the way up to the Sylvian fissure and then resected the area completely, and you can this is the extent of the lesion extending all the way up to the ventricle. And this young man presented again with frontal lobe seizures, and then there's a bottom of sulcus dysplasia anterior to the in the premotor area, anterior to the central sulcus, whereas MEG dipole cluster was posterior to the central sulcus. So to sort out the discordance, he underwent implantation, cortical stimulation, and then actually the ictal onset was found to be at the corresponding to the bottom of sulcus dysplasia. So he underwent resection of the dysplastic tissue anterior to the motor cortex. This is the motor cortex. So in the premotor area, a complete resection was done. After the resection of the depth of sulcus dysplasia, there was persistent spiking even from the motor cortex region. So he underwent multiple subpile transection of the anterior bank of the motor gyrus. As we understand that the posterior bank, if it is preserved, there will be a recovery of function. So with intense and extended rehabilitation over a period of time, he recovered from his deficit. Of course, this is a young man who had a dysplasia in the leg motor cortex, and he underwent implantation, and then the actual onset was identified. And then small area of focal resection was done. As expected, he developed deficit, but eventually he recovered. This young lady presented with peri-Rolandic seizures, and again to sort out the function and epileptogenic zone, implantation was done, and the onset was found to be posterior to the central sulcus with propagation to the motor cortex, and then she underwent en-bloc resection. This lady presented with chronic seizures, and then when she came to our institute, she was in focal status with epileptic encephalopathy, and also developed movement disorders which required subsequently after admission to ventilatory support. You can see the nature of she burned her right hand during one of those events. She had the persistent infiltration in the C3 area, and the only abnormality we found is a small hyperintense signal in this area, which is a post-central cortex. And we used, she was taken up for surgery. We used navigation. We have used intraop monitoring, electrocorticography. We used depth electrode to look for the hyperintense, the area depth of sulcus. And actually, we missed the lesion, and her symptoms persisted, and then she was taken up for resurgery within a week's time. And this is the depth of sulcus dysplasia. Professor Rutka has mentioned that this looks slightly different compared to rest of the brain. This is a firm, and it's sometimes gelatinous compared to the adjacent. This is a cortex inside the white matter. This is the depth of sulcus dysplasia. And gradually over a period of time, she made recovery, and this is she is at 1 year after
कैसे हो
surgery.
कैसे हो कैसे हो बताओ
You can see her burned hand.
ठीक हो अभी
Now, this young girl presented with multifocal seizures with multifocal cortical dysplasia, but she has got no motor deficit, and MR as well as PET showed normal anatomy and metabolism of the motor cortex area, and then she underwent motor sparing hemispherotomy. This young girl presented with seizures where she to have respiratory impairment. No seizures, and she's not required multiple times. She required ventilatory support, and only there is a hyperintense signal was found in the occipital area, and my neurology colleagues opined that this could be her symptoms could be like a biomarker for SUDEP. So she was taken up for emergency surgery, not only to control her seizures but also to save her life. And this is the right occipital lobe, and with informed consent she underwent occipital resection, and this is appeared to be the dysplastic area. So depth electrode showed persistent spiking in that location. So the resection was extended, and subsequently even from the temporal neocortex as well as from the hippocampus there was persistent spiking. So through the resection cavity, through the temporal horn, we extended resection, and then even hippocampus was disconnected. And subsequently, after surgery, she stopped having seizures where there was a respiratory impairment, but continued to have focal seizures, and then gradually over a period of time, with the rundown phenomena, she improved. Of course, with experience and with technology, we are able to take care of several such patients. This is a young lady with a DNET we were able to identify the optic radiation and then preserve and then resect the lesion. This is a young child with a complex DNET who underwent surgery and then doing well. This is a young lady with ganglioglioma extending all the way up to the ventricle, which underwent resective surgery with no deficit. Of course, some of our patients had deficits, and we were concerned because the rehabilitation services are not widely available to all these people. So we take care to avoid and minimize deficits. And finally, I would like to leave with a few comments, especially for the benefit of young neurosurgeons. If you want to develop epilepsy surgery, you should have a referral base and with a good team. Your progress should be stepwise, starting from simple to complex cases. And even among the MCD, there are simple cases as well as complex cases. Strategy is from non-invasive to invasive evaluation. Every effort should be made to identify and resect the lesion and focus. And of course, efforts should be made to avoid deficits. And there are difficult cases like MR negative lesions extending to the eloquent cortex, type 1 FCD, and those who are requiring invasive evaluation. These are all negative prognostic factors which will help us in planning and counseling also. Of course, lesions involving eloquent cortex, always there's a discussion, debate regarding whether cure of epilepsy is of primary concern or avoiding deficits. In our strategy in dual pathology is to resect both lesions wherever possible, and we always try to use pre-habilitation as well as rehabilitation whenever we suspect deficits. All our tissue, epileptogenic tissue resected is preserved in tissue repository at NIMHANS for research, and we take part in demonstrations and training young neurosurgeons in these techniques. And this is my team at NIMHANS. And also I would like to acknowledge several institutions which supported us. I worked as well as visited all these institutions worldwide, and I'm grateful to all of them. Thank you very much for your attention.
Thanks, Bhaskara. That was great. I'd really like to commend both speakers. Bhaskara, for your incredible pathological tour of the breadth of what you see. I think, having visited you in Bangalore, it's amazing what comes through the door. As you said, the epilepsy programs there have developed a little later than some parts, for instance, in North America, and with a very large population base, it's amazing the pathology that you see. And so thank you so much for sharing that with us. And Jim, for talking to us about some of the, not just genetic repercussions and ramifications of what we're learning, but also how do we minimize things as we go. And it brings up a lot of questions. We've got a number of good questions in the Q&A, which we'll get to, but just kind of a linked question to both of you, which is, when we're talking about using laser ablation versus intracranial monitoring and when we need to monitor. So there's the depth of sulcus dysplasias, which you both showed several of, and then there's other dysplasias, things where you think maybe it's type 2 or type 1. So how do you decide when a case is appropriate for minimally invasive alone? And a secondary question on that is the other end of that. There's older literature that you need to resect the lesion plus the ECOG positive zone of dysplasia. There's earlier studies, particularly in type 2 dysplasia, that there is an epileptogenic pattern, an interictal pattern, and if you don't resect all of the ECOG area, you won't be as successful surgically. So how do you balance minimally invasive techniques versus actually expanding resections beyond the lesion based on ECOG?
Thanks, Guy. Maybe I'll start first and Dr. Rao can add, but it's a really great question. And I think in resource strapped environments, and also in even where we are, it's a reasonable first step to, if everything is pointing to the area of the lesion and the lesion's quite distinct and it's in a fairly safe entry site for removal. As I mentioned, with many of our cases, we'll proceed with resection of the lesion itself, and with a good expectation that will be successful. But we've had failures, and I'm sure you all have too. And we've discovered with our failures in working them up with more monitoring, whether grid or depth electro monitoring subsequently, that the network's a bit more busy, it's a bit more profound and requires more attention than perhaps we first identified. But I think and we're all learning, and so I don't know if the jury's out yet as to what is absolutely the best approach, because certainly we've had great outcomes with navigation-based resections of lesions that you can see in various regions of the brain, eloquent and non-eloquent. But we've had some failures too. So I think we're all struggling with this and seeing where we go. Lesions like the hypothalamic hamartomas, which really are kind of a little bit different than focal cortical dysplasia. I think, we would target the lesion itself and not worry so much about the surrounding network at the moment. But for FCD lesions, I'd be interested in not only Dr. Rao, but other panelists who are here today, what their experience is evolving with and what we're learning from it.
Bhaskara, thoughts on how much ECOG contributes and how often you're extending resections beyond a clear radiographic lesion?
Yeah, one of the most important factors in our strategy is the clinical presentation. Someone who has got 20 years of history of epilepsy, hundreds and thousands of seizures, I think we prefer to resect, we prefer to do extended resection. Suppose if there's a temporal, basal temporal lesion with a long history of seizures and then with some secondary hippocampal changes, we prefer to do extended resection based on not only clinical imaging but on the electrical findings. Suppose if it's a very, I think the analogy is probably like a cavernoma, short history cavernoma resection, long history hemosiderin resection, extending resection, and then if there is a long 20-30 years of epilepsy, so we have to look for network. So more or less similar strategy is used in our setup.
Other thoughts, any of the other panelists on extent of resection, invasive monitoring, ECOG based for focal cortical dysplasia?
I would still like the presenters to detail a little bit more on the strategy. If you see a lesion on MRI and it's the bottom of the sulcus type of thing, it's likely type 2B cortical dysplasia. How often you perform? I'm just dividing the discussion in small issues so we can get more objective responses. How often would you use any invasive study in this kind of patients? It's very small, clear cut, likely to be cortical dysplasia. How many of these patients would you investigate, and how many would go directly to image-based resection or ablation?
Jim, you're muted.
So yeah, thanks. So it's a good point, Arthur. Really good, actually, and so just as Dr. Rao mentioned, we do a lot of pre-op investigations, right? And just as you do, we would have all this seizure semiology. We'd have the PET scanning, MEG at our facility. We would do as much pre-op testing as possible to see what the concordance rate is with respect to the bottom of sulcus dysplasia. And if everything looks pretty tight and confirmatory, then we would not do monitoring typically. We kind of learned from that experience. And I would say that most of the time it works out, but we do have failures, as mentioned, and then you can come back and do stereo EEG or whatever to kind of clean up the network afterwards. But so we would do that, I think, most of the time first. But as I mentioned, we're still trying to pool all our data and figure out what is the best strategy. But if everything, as mentioned, looks really tight, it's short history of seizures, it's compact, and looks like we can avoid monitoring of any type, we'll try to do that.
Let me ask you both a question while we're on the topic of bottom of sulcus dysplasia. So two related questions. Jim, one of our participants had a question on that frontal one you showed where you had to do ablations on both sides of the sulcus. And the issue there is that actually in some ways you end up making a bigger ablation than you would a focal resection, and your thoughts on that. And then comparing with that, Bhaskara, you showed the case where you went down to the ventricle, and can you both give your thoughts on, with bottom of sulcus dysplasia, do you think you need to follow that trail to the ventricle or not? Because obviously the risk goes up in the white matter significantly.
Yeah, thanks. I mean, I would say for the laser ablation, the early scan that you see after the ablation is not what you get 3 to 6 months down the road. So you should probably wait to see what that looks like, to see the evidence of how much necrosis and injury there is in the area. But we've been pretty impressed that what we've targeted with laser ends up to be what we get 3 to 6 months down the road. You get a lot of early edema, but that doesn't necessarily equate with necrosis in the final image. So I can show you some delayed images that look kind of exactly where the laser burn was supposed to take place. So I would say that, you wait it out and see, but yeah, you may have more of a burn if you're doing both sides of the sulcus than if you were to resect that surgically. But our patient left hospital the next day, and maybe that would have been case with the open procedure as well. But it's super well tolerated by the patients, the laser ablation by and large. And so I think that using a minimally invasive approach has some advantages referable to the length of stay in hospital, the complications that can occur, craniotomy versus burr hole and so on. And then for the transmental question that you asked, should you chase that into the ventricle? Yeah, I haven't done that regularly, to be honest. I think I've asked quite a few epilepsy surgeons, and some do and some don't. So I'm not sure what everybody's approach is here and whether you think that that's a necessary component to get right into the ventricle for excision. Years ago, I asked Gary Mather that question, and he says he always does it, but it hasn't been my practice.
Yeah, even in my experience, in about 90% of bottom of sulcus dysplasia, there is no need to extend the resection up to the ventricle. The case I showed, as well as about 10% of bottom of sulcus dysplasia in our series, have got a transmental sign. My preference is to extend the resection up to the ventricle. Of course, we always approach to the non-eloquent area. We do fiber tracking, and we can, some cases we do introp stimulation, and then we'll make sure that we are not close to the corticospinal tracts. In my initial series, some patients had deficits. Of course, so if it is in the eloquent cortex, we are a lot more careful not to extend the resection.
Did any of you had the opportunity to examine the transmental thing? What is in there? In at least we got the opportunity to examine 5 of these transmental, removed and blocked, and there were no neurons there, just gliosis. So do you know where is in there, Bhaskara?
The case which I presented, histopathology was done, and then there were abnormal neurons, even in the white matter, deep in the white matter. Of course, that could be appreciated even on imaging, as well as even during surgery also. The transmental dysplasia, it's not pure white matter tract, and even on the MR as well as surgical specimen.
So you're implying that the transmental sign is comprised of neurons?
Yes, yes.
So it'd be interesting that actually provides a research topic for some of the participants on the group here, because obviously we need more information on that, right? These cases are not that common, so it'd be nice to get some more pathological reports.
Can I comment, Guy?
Please, Bertel.
Yeah, I have first one comment for first Professor Rutka. I really appreciated that you mentioned the experience of the sort of different feeling of the tissue in a dysplasia. So when you sort of plan for a resection, then you have the MRI, fMRI, and everything else. But you should never forget the fingers of the surgeon. That is extremely important, I think. And then just to comment this with the transmental dysplasia, I never took away the transmental dysplasia due exactly as what has been mentioned, due to the high risk in white matter, and probably it's not necessary. But I might be wrong, so future research may give an answer to that. Thank you so much, both of you.
Jim and Bhaskara, maybe you, because I was going to ask if you could build on that exact topic. So particularly, these are predominantly pediatric patients. Sometimes functional monitoring is more challenging in these younger patients, and maybe you could comment on that, and how much you're actually, your extent of resection is truly guided by your surgical feel more than your electrodes, more than your imaging. Because if the consistency hasn't gotten to normal boundaries, do you think it's likely still dysplastic tissue there?
Yeah, thanks, Guy. That's a great point. And I mentioned that with one of the videos I showed, and I think Bartel mentioned it too. I mean, it is very important, and I'm surprised sometimes when I get into these areas that it clearly demarcates itself and is totally different from the surrounding normal brain. So experience, there's no substitute for experience when it comes to these types of resections. And the more you do, the more you kind of get a like hands-on feel for what needs to come out and what and when you've reached the boundaries. And obviously we're always in the peri-Rolandic region, being careful so as to stay within the boundaries of the lesion that we've mapped out. On the other hand, we always have continuous neuromonitoring firing while we're resecting and trying to be as safe as possible as we're doing the resection, but we will continue to resect as long as there's abnormal tissue that we can feel that feels as though it's all contiguous and continuous with the lesion until the lesion is removed. It's not a tumor necessarily, but it clearly has boundaries that are often distinct and you can appreciate.
Yeah, can I make a question?
Right, can we have Bhaskara comment on that first?
Yeah, I always go to OR with a plan to resect. The extent of resection is based on the size, the location, and the surrounding cortical eloquence. I have no problem as far as non-eloquent areas are concerned, but of course all of us have got difficulties in operating in the peri-Rolandic area. There the resections are conservative, and then that led to failure in our series also, just like any other center.
Wait.
Sir, I just want to comment about the cases with extensive cortical dysplasia. You know, it's how much is necessary to completely resect the entire lesion for an optimal outcome. So we are talking about attempting to resect the entire lesion, but in many of those cases that it's not possible. Is this truly necessary to resect the entire lesion? There are portions of the cortical dysplasia that are non-epileptogenic. So how to define what would be the extent of resection? The pure lesional resection probably is not necessary in some cases. So that's why I would like to heard what Dr. Rutka and Bhaskara they have to say about larger cortical dysplasias, how they manage those. Do they consider those patients non-surgical candidates because they cannot resect the entire lesion, or you approach this with an invasive monitoring to try to identify the epileptogenic areas on that large cortical dysplasia and then offer surgery?
Yeah, thanks, Jorge. That's a really good question. And, you know, my presentation today was not about these extensive dysplasias. And some of them, as you know, can take up the whole hemisphere and require, you know, hemispherectomies. But for, let's say, subtotal hemispheric, but large dysplasias that you're referring to, I don't think we would approach those necessarily going right into surgery and trying to do complete resections, because many of them will straddle or bridge multiple lobes of the brain. And so in those particular instances, we would pretty much opt most of the time for invasive monitoring, trying to characterize where the epileptogenic zone is and where spread is, where the network might be, and take care of it on a invasive monitoring basis. So that's a different question than the presentations that you saw from both of us mostly today. But that's a really good question, and the extensive ones require, I usually think they'll require invasive monitoring.
Yeah, my understanding is that within the lesion, large lesion, there are some areas which are more epileptogenic, some areas are less epileptogenic. To differentiate the extent of epileptogenicity, in our practice, we will not do implantation. Our implantation is more to identify functioning tissue, not to differentiate more epileptogenic and less epileptogenic, because the strategy is to resect the complete lesion. We have done few multilobar resections as well as hemispherotomies for hemimegalencephaly. But of course, I wish, apart from the invasive evaluation, I hope we'll come out with some sort of non-invasive evaluation showing which part of the lesion is more epileptogenic, so that more targeted therapy can be achieved. I'm sure things must be in the pipeline.
Well, I think that you both commented on this, that we're always stuck in the balance between function and seizure control. And if you have somebody who has a dysplasia, for instance, in leg motor, and they're having 50 or 100 or even 20 seizures a day, that patient usually over time will be losing function from those seizures. And so then you're making a decision over time with the patient and the family. We know we're going to have a deficit in order to try to stop the seizures. Here's what we think will happen, but those are difficult conversations to have. And maybe you could comment on how you with your patients and their parents get through those conversations and find that balance.
I just
thanks,
wanna
Guy.
go ahead, Jim.
Okay, thanks, Arthur. So just very briefly, we've and I know others of the panelists online have published on, this kind of function and extended lesion quandary that we find ourselves in, and we also have published on peri-Rolandic area, like massive resections, and what does that implicate to the child and welfare afterwards, and these seizure disorders can be profound in this area, and with hundreds of seizures a day, and in those cases where we've actually taken motor away in some instances because because there was a hemiparesis, let's say, to begin with, but also because it was necessary to get better seizure control, even if they're not in a better seizure state, or let's say seizure-free state, but they're better, like much better in terms of seizure control, the families typically will accept a deficit that's worsened if they can get into a better seizure state, and that's been our discussions. But it's variable, and as you said, you must have this conversation in detail with the families, and they all have to kind of agree to what you're weighing in balance here: seizure freedom versus function. And it's tricky, but yeah, in our series that we published, there were definitely some families who said, we don't care about the hand function, just get the seizures away as best as possible. And that required a motor resection, in these extensive cortical dysplasia cases. I think we're learning from our experience that, hand function is important, and maybe we shouldn't offer that as a solution. But this is where discussions get very interesting with your epilepsy surgery teams and what you accept as function limitations versus, seizure control.
Yeah, the case I presented, a young man with frontal nodular heterotopia with secondary MTS. For 18 years, they have been consulting various institutions in India. They had been to UK as well as to United States, discussing and debating the same issue, deficit versus cure. But eventually, epilepsy became progressive, and then when he came to us, they were desperate to get rid of both lesions. So, of course, patients and families are a very integral part of our decision making. Multiple consultations. I think maybe one reason why people wait for 18 to 20 years before surgery is to go through these extensive and multiple consultations and opinions. I think probably we should have more objective way to predictive analytics. Maybe I hope big data will give us some idea about seizure cure probability versus deficit probability, and then based on those modelings, maybe we can take better decisions in future.
Since this is a surgical technique discussion, I just want you to focus on very brief 3 practical things. The one is the use of intraoperative electrocorticography. How often you use intraoperative electrocorticography, and in which type of patient, and what is the level of evidence that intraoperative corticography adds to the results in these patients. So ECOG.
Yeah, so we used to use it a lot, Arthur. Don't use it anymore. Like I would say almost never are we using it.
Yeah, for a small discrete lesions, we are not using it. But if like we suspect type 1 dysplasia, the focus and lesion are not very well demarcated, then at times we depend on intraoperative findings. Of course, we know pre-op itself whether interrectal spiking was profuse or not. So if preoperative easy interrectal spiking is not profuse, then probably we cannot expect a great yield during the corticography.
Thanks. The other recurring question here is about specimens. If you are doing ablation, laser ablations, you don't get specimen. What is the feeling there? That getting specimens is just an academic issue, or are we losing any information for patient care?
Yeah, thanks. So we'll do biopsies during laser cases, particularly for tumors, of course. But even in FCD, I think we can still learn from our FCD cases. So, but we don't want to change the conformation of the lesion. So if you're near a ventricle or something, or CSF space sulcus, that you're worried that you're going to change the dynamics of where the lesion is, we may opt not to do a biopsy and just proceed with ablation. But I would say the majority of times we're getting tissue that we do at the same time as the laser ablation. And you know, I think it's helpful. It's more than academic, as you know, because some of these lesions are so subtle. Yeah, you want to be sure that you're ablating something that has a name to it, like a classification of one of the focal cortical dysplasias, as opposed to an imaging finding that has like no pathological correlate.
Arthur, thanks for asking that particular question. As you know, the resective surgery is coming down in probably United States as well as European centers. In India and China, the numbers are multiplying. I think this is one, and in our setup, we preserve all the tissue. This is one area where institutions across the continents can collaborate and then use the tissue for research. I'm sure the outcome will be substantial. Thank you.
And it does bring up something important, which is, Jim, all those genetic studies, for instance, and a lot of the advances that we're learning in these patient populations depend on acquiring tissue.
Yes.
And some of our most difficult to treat cases, which are more subtle on MRI, even more subtle than bottom of sulcus, are things that pathologically come back as FCD type 1. And we've really talked about predominantly 2s. Maybe you guys could talk a little more about what you've learned over time about FCD type 1 and how you determine extent of resection in those cases as opposed to MRI, less subtle areas and pathologies.
Yeah, thanks, Guy. The FCD ones are tricky, and you know, there's quite a bit of variability from center to center in how neuropathologists will read some of these specimens in any case. But yeah, we're finding that margins may be more blurred, won't be as discrete. We'll have more issues in identification of what the extent of resection could be in some of these areas. But it is, I think, for the surgeon comforting to know that there's pathology within the tissue that you remove, even if it's FCD type 1 versus FCD 2 with, you know, balloon cells and things. Yeah, I think all of this helps. And that's why I mentioned at the last question that it's important for us to analyze these specimens and make sure that we know what it is we're dealing with. Because as Dr. Rao said, you know, once we get enough in the pipeline, enough of these bank specimens with their imaging correlates, you pull in big data, and then it might turn out to be an imaging biomarker, or maybe a blood biomarker as opposed to a tissue biomarker that we'll be able to use to come up with a diagnosis. You know, this is in the future.
I had surgical failures with FCD type 1. What I understood is that type 1 dysplasia and type 2 dysplasia, the migration is at different gestational periods, intrauterine periods. So the what we find on imaging clearly as hyperintense signal is more because of the glial signature, and that will have no function. That can be resected very easily. No function, type 2. Whereas type 1 will have function and no demarcation. So it's difficult. Non-eloquent, generous resection. Eloquent, near eloquent cortex, I always had problems. I hope we'll be able to find some solution.
Any other thoughts from the panel on experiential knowledge on FCD type 1 for participants?
No, not really FCD type 1, but I might comment on the importance of the pathanatomical diagnosis. Since I work quite a lot with the Swedish registry of the epilepsy surgery procedures, I have huge material. And I must say that in those cases, you find a very unspecific diagnosis or someone just gliosis, then you know that this will be a bad outcome. So I think it is very important to have a specific diagnosis, but also, as has been mentioned, specific diagnosis and specimen for future research. That's my opinion.
So
Go ahead.
no, I just want to comment dysplasia type 1, non-lesional MRIs, that's probably what we're talking here. Most difficult cases, very challenges. We always use invasive monitoring for those cases. Anatomic electroclinical correlations are essential. And I quite frankly don't know if truly this is a true pathological substrate cortical dysplasia type 1. The observation rate of those are so different. You can show the same slice for the pathology 1 week after, and he may come up with a different conclusion, a normal, a non-lesional. So it's difficult, it's so subtle. So I'm also questioning the existence of cortical dysplasia type 1. It's controversial, but it's very hard, very hard.
We are getting to the end. I just want to go ahead with another techniques. So what about multiple superior transections in dysplasias in eloquent areas? Do you do it? When you do it?
Again,
Yeah, thanks. Thanks,
please,
Arthur. So,
yeah.
yeah, I think that we've done it. And in fact, Jeff Blunt, whose name is there, he wrote up our series of patients ages ago when we were using it. And yeah, it had a role to play. And I must say, I did one recently, a case in the Rolandic area that we just couldn't resect by virtue of the family not wanting to have a deficit and yet wanted to have better seizure control. So we opted to use it. So it's a technique that you can use sparingly, I would say, but you're going to have to watch and follow your patients, and there'll be failures, down the road. But it is an option, and I think we've all got experience with it, but I don't think many centers are using it as a primary mode of therapy for eloquent or Rolandic area epilepsy these days.
Yeah, what I understand is that MST will make a disorganized cortex into much more disorganized cortex. So in general, it is not used. Also, MST in routine epilepsy surgery, only 4 millimeter up to interneurons only we reach. Whereas in for example, depth of sulcus dysplasia, it can extend quite deep. MST usually will not extend to that depth. So it's not done in general. But the case I showed you, out of desperation, it was done on the anterior bank of the motor cortex. So occasionally it's being done. And also it's always combined with resective surgery. So its efficacy in isolation is difficult to predict in these cases.
Arthur, one more separate technical area. We have a couple of questions we haven't addressed. So Jim, you showed that fascinating case where you did a resection and the small amount of residual dysplasia you were able to get with the laser. We actually published a similar case a few years ago where we planned it staged in similar fashion. So laser is one way to go after residual areas of dysplasia that are there. We've got a couple of questions from speakers about radiosurgical ablation of residual, or possibly even using focused ultrasound. And I know that's not something that would be available, but obviously you guys have a large focused ultrasound research team working in Canada. Can either of you comment on radio frequency or focused ultrasound for residual dysplasia, or any of the panelists?
Yeah, so we just accepted a paper guide for publication on focused ultrasound from the Miami group. They were using it for a variety of lesions, mostly mop-up type of cases, like for hypothalamic hamartoma and redo cases. It was a good strategy. It worked well. Morbidity was very low, and targeting was extremely precise. So I think it's going to be an avenue for us to pursue further. And we have a case at our institution, hypothalamic hamartoma, that's just waiting for our Health Canada approval, so we can go ahead and try it in a residual hypothalamic hamartoma case, because it failed like 3 or 4 attempts at laser. So that might be an example of it. So I think it's coming down the pike. As for radial surgery, I mean, that's been used for hypothalamic hamartoma, but for focal cortical dysplasias, I haven't. And I mean, it could be, but I think that form of energy, as opposed to heat or thermal energy, has some downsides to it, which I would steer away from in a young child in particular.
And how about radio frequency ablation? Do you do that at all in Canada?
No, we haven't, but if you go to China, maybe in India, Dr. Rao can speak to this, but yeah, this is a very common approach. Radio frequency lesions of hypothalamic hamartomas and other focal cortical dysplasias, very frequently used. The trouble is I don't think you can monitor as well as you can with laser in terms of the final, lesion that you come up with radio frequency. So it's not as precise, in my opinion, as the laser and the thermography that you get in real time with the intraoperative MRI.
Any thoughts? Any thoughts on?
We have a gamma knife at our institute. Our experience is limited to only hypothalamic hamartoma and no other indication. And there's no focused ultrasound in India. And the 2 institutions, one in Delhi and another one is in the state of Kerala, the RF lesions are done for not only hamartomas but for probably a few cases of even malformations also were done, but it's not published data, so I cannot comment about the outcomes.
Any thoughts on cortical stimulation for cortical dysplasia in eloquent cortex?
Yeah, not from our experience, so I have no personal data to share with you.
I can tell you, we've tried RNS on a limited number of Rolandic area, focal cortical dysplasias, subtle MR abnormalities where the families did not want a deficit. And so far, our experience has not been particularly positive.
I know from literature, Dr. Benabid has implanted, I think, probably DBS in motor cortex cortical dysplasia. This was published several years ago. There may be other reports.
One other final question for you two, which was brought up. I think it's an excellent question, which is that do you approach FCD differently in a child versus an adult, both in terms of the plasticity of the patient to potentially recover, as well as the extent of resection?
Yeah, so Guy, my experience is almost exclusively in children up to age 20. So I don't have much experience in the adult population, but yeah, it'd be good to hear from Dr. Rao, because he showed great cases of both adult and pediatrics, right? So Dr. Rao, maybe you're the best person for this one.
I think probably all adult surgeries are all either delayed or neglected childhood epilepsies. So our preference is always to catch them young and then take care. I think probably resection strategy is same, but children, if I find a child with hippocampal sclerosis, I always look for another developmental malformation, because it's more likely to have a dual pathology. So children, I think we should take care of them earlier to prevent very disabling consequences.
And Jim, getting back to the pediatrics, there's a lot of debate in the literature as to up to what age language can reorganize for whatever the pathology. Can you give us your Toronto thoughts on that in terms of at what point do you think a child will sufficiently switch language?
Yeah, thanks, Guy. I mean, it's not based on any hard and fast rules, but age 5, I would say you can probably expect some language transfer. I can say that with experience with some hemispherotomy patients where language completely developed on the opposite side, even though pre-op we had mapped language to the side that required the hemispherotomy. But once you get into like ages 7 and beyond, it's really, I mean, it's almost limited opportunity, I think. Between 5 and 7, I think is a gray zone. So that would be my comment on language transfer, Guy.
Other final questions from anyone for our Jim, by the way, and Bhaskara, thank you so much, just for your, not just for your talks, but for a really broad-based discussion. And you know, we like to cover as much surgical topic, and I think we've probably covered most of what we can on the area. And so thank you, both of you, so much for great talks and also a great discussion.
Thank you.
Thank
Thank
you.
you.
all.
Thank you.
Thank you.
I will open the post-webinar link.
Yeah.